Yeah, so here's some pretty neat stuff. So the ProDisc study, it was completed for 2 levels, a very unique study design because it allowed the surgeons to choose which of the discs they wanted to use at the time of surgery. So you could do either on pre-op trialing or preoperative measurements or looking at the x-ray or an actual trialing to use either the ProDisc Vivo or the ProDisc SK in different varieties. And the other thing is the disc was just approved as a 2-level study last week. So this is brand new data. And who's buzzing? And you are the first group to see this. Corey, we fix that, or Ben? So this is like fresh off the presses. Too bad Sig's not here, but this is how the sausage is made. These studies take a while, they get done, the data gets submitted to the FDA and finally gets approved, and then we can start talking about it. So just a quick brief overview. Dr. Terry Marnay, all the way on the left side, was the inventor of the ProDisc. It started with ProDisc L. He worked on miniaturizing it into a ProDisc C implant with the help of Dr. Rudy Bertagnolli, a German master surgeon, excellent technical surgeon, and then with the input also of Michael Meyer, another German surgeon who was really the one who pushed for a convex upper end plate. And all this occurred over several decades, but it was smart people innovating and thinking together and working together. The study of the original ProDisc, the one with the larger keel, was started in 2003, enrolled pretty quickly in those days, 13 center, 33 surgeons, 209 patients, randomized 1-to-1 to an ACDF, as all of the early cervical arthroplasty studies did, and then all the 6 post-op data points out to 24 months, and got FDA approved for single-level use in 2008. So it's been part of our culture for 18 years. 2-year outcomes data was reported in the Spine Journal in 2009. 5-year outcomes data of single-level original ProDisc was reported in Spine in 2013. And 7-year was reported in JBJS in 2015. And just 2 fun facts. JBJS is a very hard journal to get published in, particularly a data-rich study like a multi-center or randomized trial. They go through every decimal point, and everything was a fight, but it's a prestigious journal to be in. And the other fun fact is this is the only data set that's reported that used an independent data analysis, not using the biometric data that was submitted by the company analyst. We approached Dr. Kopjar, who was at University of Washington, and actually the authors were willing to pay him for his time so that we could say that this was independently reviewed, and he was nice enough to decline payment. He said, I'm an academician. He said, if I can be a co-author on the study, then you don't have to pay me, deal sealed. But this is one of the few studies that used independent analysis of the supply data. So the 2 unique things about the study were that it is the first one that is really a disc-to-disc randomization, contemporaneous randomization to an already existing control disc, which was the Mobi-C. And Mobi-C was a tough disc to use as control because it was very successful. It's, financially one of the more successful discs as far as global sales, had been around for a very long time. And you're kind of betting your outcome that you're going to be no worse than something that's good. If you really had to think about it as a business person, you'd want to compare yourself to something that's bad to make it easier to look good. So, they picked a tough control. And again, it was the first disc in a 2-level study where the surgeon could determine which combination of the 2 different discs, the Vivo and the short keel, they wanted to use based on their independent judgment and based on the patient's anatomy. So this was a multi-center prospective randomized study, started enrolling in 2019, ended in 2023. You can see 31 sites, 58 investigators, all within the US. They didn't use any OUS sites. And the FDA approval, which was just done, was data that had been supplied to the FDA through December 2024 and included 93% of all subjects. And I just wanted to shout out to Celeste Bjornson, who's the head of research at HSS, helped me out because obviously this data became public just very, very recently, and she was able to be right there with the data for me to share with you. So it was a 2-to-1 randomization between the investigational group, which was the 2 ProDisc Cs, and the control group, which was 2-level Mobi-C. And the patients were externally randomized. There was no predetermination by the surgeons as to who got into whichever group, just like any of the other good studies. And I'll show you the breakdown. So as all properly prospectively randomized studies do, the demographics should be the same. You shouldn't see any significant difference in the demographics of the two study populations, or you start to wonder whether somebody was cheating. So here, the population showed no significant changes, so they were good, homogeneous, and prospectively externally randomized groups of patients. 480 patients were randomized. As often happens in these studies, especially these days with insurance taking a long, long time, 47 of the patients were enrolled but never treated because the statisticians say at some point, okay, you've got enough patients to meet your statistical goals, but we got all these patients who signed up for it, they go away. So nobody's hiding those patients. They never had the operation. They weren't included in the study. 433 patients were included in the study because they had an incision time. They went through surgery. 293 were in the investigational arm with the two ProDiscs, and 140 received 2-level Mobi-Cs in the control arm. Very clean study, follow up with all the standard FDA data points. Just some information about the ProDisc SK and Vivo, and Dr. Geyer mentioned some of them. Their end plates are a little more trapezoidally tapered posteriorly so that they can fit better between the uncovertebral joints than the original ProDisc. I have that there on the bottom. You can see that the original ProDisc was more of a rectangular shape, and also the difference in sizing between the heights of the disc as well as the width of the disc. So the short keel is a little shorter and a little bit narrower. The Vivo is just a convex posterior surface with teeth rather than a keel. The sizes are very similar in size to the original ProDisc sizing. So what made it unique, again, the surgeon could decide whether this was going to be a patient who got 2 Vivos or 2 SKs, or a Vivo and SK, or an SK above and a Vivo below, all those permutations. So there were 3 stratifications that were possible. So again, it's kind of interesting. How is this going to fall out now at the end of the day? So here's the data analysis, and that is that 62% of the patients got ProDisc C at 2 levels. 20% of the patients got ProDisc C SK at both levels, and 18% of the patients got 1 and 1. So it's kind of interesting. And again, you don't know this when you're prospectively enrolling the study. Maybe only 3 patients might have had the combination, and then kind of wasted. There's no data analysis that come out of that. But here you got reasonably good numbers. 180 patients, 60 patients, and 53 patients. So reasonable numbers so that you can look at the outcomes and say, okay, I can sort of buy that. That's going to show me something I can use. So here are the examples. So here's a 2-level ProDisc Vivo, a patient who got 2-level ProDisc SK. Here's a patient who got Vivo and SK, and then the control group, patients who got a 2-level Mobi-C. So that kind of sets the table for the study. Primary endpoints were non-inferiority to the Mobi-C. So basically, here was a disc that had been on the market for 20-some years, was doing well, very successful. Just is this these 2 variants in this new combination pattern any worse than that? That was the hypothesis to the FDA. People would say, oh, it should have been a superiority study. I mean, why? Why would you want to do that? It makes you have to have a lot bigger number of patients, much, much more expensive. And do any of us really need that to say that this is a reasonable alternative if it's not any worse than something that's already been accepted and used for 20 years? So patients that have non-inferiority, maintenance or improvement in neurologic function, in other words, no neurologic decrease, and no secondary surgical interventions. The FDA defines that as revision, removal, reoperation, or supplemental fixation at that level. So they couldn't have that. They couldn't have a major device-related AE or a major AE not necessarily device-related. And this applied to both sides. So that's the nice thing about having a controlled study also. Whatever ruler you're applying applies to both sides. So things that don't really matter to patient care should kind of net out. So you're going to be able to just analyze the things that are different between the 2 studies. So here was at 50% of the patients submitted, this paper was formulated and is actually maybe presented at CSRS, but with the preliminary analysis of 50% of the patient data at 24 months, you can see that the improvements in neck disability index and improvements in VAS for arm pain were pretty much identical. That there was, at least gross visually, there was no non-inferiority. They both did just what we expect artificial discs to do. And I'm sorry, Sig's not here because we need to beat it into him that cervical arthroplasty is better than fusion and Dr. Kepler, because they all show the same hockey stick, especially NDI, which is the only common denominator in every single study. It's the exact same fill out the blanks. And we always see the hockey stick, that patients get better and it stays better for as many years as you want to follow them. And the same thing with arm. So this was, again, 50% of patients at 2 years. But now we have better data because, ba-boom, 10 days ago, got FDA approval now based on 93% of the patients. They're just like calling the election, it's okay to do it. So here are the actual NDI boxes, showing that preoperatively, the patients in both groups, again, well randomized groups, so you don't want to see difference between those. Preoperatively, they were both hurting, drop down and stay down, and you don't see any statistically significant differences in between at any of the data points. This is NDI. Here's VAS arm pain, which is why patients come in to see us because they got radiculopathy, primary indication for it. Significant, huge, immediate improvement in arm pain that remains stable, no significant difference between the two groups. As we've mentioned a few times before, the neck pain parallels that. So a lot of these patients just have neck pain because they've been splinting their arm, but some of them, they have neck pain as part of the pathology of cervical disc disease, and that gets better with artificial disc replacement. Here, between the Mobi-C and the ProDisc, no big difference. Again, reinforcing the technology works. These are the physical component scores and the mental component scores of the SF-12, showing improvement, again, in hand, doing the same thing for 2 years in 93% of these patients. These are the measurements I was mentioning before. These are the angular motion digital measurements for pre-op and at each of the data points post-op. And of the 4 boxes there, you can see it goes ProDisc superior, ProDisc inferior, and then the green one is Mobi-C superior, Mobi-C inferior. So it's interesting to see over time, the superior Mobi-Cs have more motion. That's the hypermobility, and that's, we've kind of all discussed that before. It's also been in Dr. Pat Borden's couple of papers defining physiologic motion, that the Mobi-Cs tend to be more hypermobile. You can see it's at the superior level. Actually measured. And again, I think it's a good thing for us to have in our tool belt. We're going to figure out when patients are better served with a less mobile disc and a more mobile disc, and it's nice that we have that option. So here's angular motion. This is global range of motion. Interestingly, we don't see that big of a difference in overall global motion, even though we know that the superior level of the Mobi-C was more significant looking at the angular motion by itself. But again, nice data to see over 24 months. Translation, again, it's the Mobi-C upper levels that showed the additional motion. And again, we think we're going to be able to identify patients for whom that might be an advantage. Otherwise, you can see that the ProDisc's constrained range of motion stays, relatively stable all the way across. So the safety conclusions as submitted to the FDA's mandate from Congress in 1976 was safety and efficacy of devices. So that's the number one thing that they look for in a study is, are we hurting patients here? So the investigational ProDisc demonstrated a reasonable assurance of safety compared to the control, to the Mobi-C. So that checked the box for the FDA. The observed AE rate for the ProDisc group was actually a little bit less than that of the Mobi-C group, but not statistically significant. But again, it met the non-inferiority hypothesis. The rate of adverse events was similar in both groups. It was actually just a little bit smaller in the ProDisc group, but again, not statistically significant. They both were pretty much hand in hand. These are both good implants on the market. And the secondary surgery intervention rates were also similar, also a little bit less in the ProDisc patients, but not statistically significant or low single-digit numbers. So here it met the hypothesis. So what are our take-home messages for me looking at this data just over the last 2 weeks also? It's a very cool study design. It was really kind of neat. And if you think about how much these studies cost, and you're gambling on the outcome to design a study that's different, that you're not really sure. You're putting in some extra variables now, letting doctors figure out, which disc they want to use at what level. What if that turned into garbage? It would be like a waste of money. So kudos to the people who designed the study and funded the study and went through the study. So good study design. That the disc-to-disc prospectively randomized study is a really good way to do it because it eliminates all the head scratching when you get historic controls or demographic age match from a different study or an old fusion study or something. You always say, yeah, but. Well, there's no yeah but here. These, all the patients were enrolled and then randomly assigned and then followed exactly the same way. That's the cleanest that we can do as clinician scientists. That the SK and the Vivo for two-level disease are not inferior to MobiC in both safety and efficacy, so that checks off the second box for the FDA. And I think for all of us, it adds to what is just an incredible mountain of data that we have. And yet, so I'm still astounded at people who argue with us that shouldn't be the standard of care. No, fusion is still better. If we're believing in data, if we're scientists and we believe that we're studying this in a good way, I think we've made a really good point that cervical arthroplasty is a good thing. We've had some issues with new materials and new designs, but it's the only way we're going to learn. You just don't know. But cobalt, chrome, and poly has stood the test of time in hips and knees and peripheral joints and in the spinal implants too. We're just not seeing the issues with that. But I applaud the people who do try different designs and different materials. One of these days, material science will catch up, and we will have implants that will work just as well, if not better, than what we were born with. So that's the only way we're going to find out. So I think we're out of here. Jens, are you ready to be roving reporter? Corey, is there lunch in there maybe?
Yeah.
All right.
So I'll serve as a roving reporter. So I'm still confused. So what should I choose as implants now? So if you can go back to your summary slide. So this shows equipoise. So I have pretty much complete equipoise. There are mechanical differences, though, between the SK/Vivo and the MobiC in terms of their translational stability.
Yeah.
As we now know, every single disc level in the cervical spine has a distinct anatomic and mechanical function that we've underappreciated. Like 5, 6, 6, 7 are the main action discs. 2, 3 is surprisingly stable, rarely, if ever, needed for a disc replacement. 7, 1 is highly suspect in terms of what it does if there's a disc replacement due to mechanical differences of the bone density at T1. But are there anatomic differences of the level? And then are there physiologic differences, like a little small lady with fragile build, provided she fits in the FDA criteria, versus a robust big football player who wants to go back to head-on-head collision sports?
Yeah, Jens, I think in the 17th motion preservation course, we will have answers to those things. But I think we're just laying the groundwork
10 years,
now.
put the clock on.
Yeah, we're laying the groundwork now. But I think you're right. I think there will be level-specific or need-specific criteria that will help us direct which disc should we be using, a more constrained, less constrained ball and socket or socket and ball. All those things we'll learn it. We're at the infancy now of arthroplasty. For me, I've used the MobiC in ex-football players, in EMTs, and people who are doing heavy stuff because, I think it's solid. It's, cobalt, chrome, and polyethylene with a lot of articular contact surfaces. So I've tended to use that in very high demand people, just empirically, but I think we're going to be able to get very good stratification as time goes on to answer those questions.
Dr. Sherlock before talked about that she's getting a CT scan routine, and maybe she can comment on that. So does a CT then impact your decision on an implant choice?
Coming your way.
So if you map out your sagittals and axials, does that influence what you'll choose?
That's a great question. And it does. I think that, for both the cervical and lumbar, just looking at the sagittal profile and looking at how, concave the surface may be, it's always the inferior surface of the superior level, and kind of getting a feel for on a device that has, maybe a little bit more of an anatomic profile, let's say like the Vivo versus, the Mobi, like how is it going to sit? And so I do consider that. I think all of us consider that pretty heavily. Something that obviously with intraoperatively trialing, we can also get a better feel for some of that. If we're going to do a ProDisc and we have both of those options on the table, that gives us that opportunity, because sometimes what we look at on the CT, sometimes when you trial, it's a little bit different and you might change your mind. So.
Great.
Super. Great, thank you. Thanks for everybody's attention this morning.